SVMIC. We are a Tennessee-based professional liability carrier. We are mutually owned, which means that we are owned by our physician policyholders. So there are no outside shareholders, no outside interests that affect our direction, our ownership, or our decision-making. We're putting this program on today here at Erlanger for you all, and we have some representatives from SVMIC in the back. I'm going to start with Julie Loomis, who is an RN, JD. She's the Assistant Vice President of Risk Education, the department that puts these programs on. And then beside her is Debbie Hudson, who is a business development executive that covers this area. If any of you have any questions about Malpractice Insurance Company or SVMIC, please feel free to ask Debbie, and she'll try to answer your questions. As you came in today, you all signed in and registered. If any of the residents have moonlight, we need to get you to sign a separate policy out there for us. Hopefully you were asked as you came in, but if you were not asked that or you missed that, please sign in if you moonlight. There are some other forms that need to be signed. If you need CME or MOC credit, please fill out the yellow form that was out at the front table. You can pick one up as you go out if you didn't get one. There's also, if you're getting MOC credit, there is a test that you must take to get your MOC credit today. So you need to pick up that test, fill it out, and turn it in to Alyssa as you leave. If you will, please take a moment to silence your phones and mobile devices. Just put them on vibrate. That's perfect timing. And our program today is on the opioid crisis and prescribing. As you've probably seen the news and you've heard about, the opioid pandemic is America's worst drug crisis in its history and has been declared a public health emergency. This year's program, Responding to the Opioid Crisis, Law, Policy, and Practice, examines the current opioid crisis in Tennessee and offers a peek into the new laws that were just passed on opioid prescribing. In fact, we've had to make changes throughout this year to this program because the legislature is constantly making changes to the law. Our speaker today is Walter Fitzgerald. You may recognize him if you've attended previous programs on prescribing. Mr. Fitzgerald has presented a seminar on controlled substances for SVMIC every other year since 2010. His experience educating healthcare practitioners and students in Tennessee has extended over 3 decades. He served on the University of Tennessee Health Science Center faculty for 24 years, after which he served as founding dean of the South College School of Pharmacy in Knoxville. He is a licensed pharmacist and an attorney in Tennessee. And Walter brings a wealth of knowledge and experience to our program, and we're happy to have him back with us here this year. So with that, I'm going to introduce Walter. Thank you.
Thank you, Jeff. Well, good afternoon. Let me add my welcome to Jeff's welcome. Appreciate all of you being here today. I'm going to work from back here. I would rather be back here and us talk rather than me stand up there and lecture. So we do have a lot to cover today, so we're going to jump right into the program. One of the things that SVMIC had a really great idea, they have many great ideas, but this one was to build into our program this year a clinician that is incorporated into the PowerPoint slide deck through videos. And the clinician is commenting from a clinical perspective on something that either I've just talked about or we're about to talk about, because I can't bring that clinician perspective to you like a clinician can, because I'm not a clinician. It also avoids you having to listen to me for an hour and 45 minutes without some break in that hour and 45 minutes. So what I want to do is I want to introduce you to Dr. Greg Mancini. Some of you may know Dr. Mancini if you did any of your rotations in medical school in Knoxville or have been up there for other reasons. So let's meet Dr. Mancini.
Hello, my name is Dr. Greg Mancini, and I'm Associate Professor of Surgery at the University of Tennessee. I want to thank SVMIC for allowing me to give you this talk today. And I really want to talk to you today, not as a TMA member or the way that our government may talk. I really want to talk to you physician. I want to really talk about our role as it is in our opioid crisis. And it all starts with one thing. It starts with a prescription. These issues always start with ourselves, right? We analyze our own practice and begin to realize that there needs to be a change. And the thing that I want to begin the discussion with you all about is how if we're going to address this opioid crisis, we're going to do it one patient and one physician at a time. But at the end of the day, that transaction between us and our patients in which an opioid prescription is made, that's where the real difference is going to be made.
In our state, as in many states, there are multiple factors that are contributing to the opioid crisis. So let's take a moment and talk about these in Tennessee. The first is inappropriate prescribing of opioids. Now, some of you may have seen the 60 Minutes episode last Sunday where they interviewed the physician in Florida that's been sentenced to 115 years in prison. And some of the prescriptions that he was issuing were giving patients a quantity of 100 oxycodone a day. Well, I think we would all agree that is, I know there's no ceiling dose on opioids, but goodness gracious, that seems like an awful lot of opioid, oxycodone, 100 a day. The other inappropriate prescribing, though, that we're more concerned about right now in Tennessee is this new law. Because anytime we enact a new law that has a lot of technical requirements like this law does, we put you at risk of transgressing or violating that law. Not that you would do so purposefully, but because you don't understand the requirements of the law. So we're going to spend a lot of time today talking about and making sure you understand those requirements. Well, let me give you an example of what I mean by that. Who has written a benzodiazepine or a gabapentin prescription since July 1? Raise your hand real high. Leave your hands up real high. If you put an ICD-10 code on that prescription, leave your hand up. Anybody? Okay. So you weren't required to do that under this new law. This new law only applies to the opioid class of drug products. Now, the reality is that's not a bad transgression, that's a good transgression, and here's why. Because you gave the pharmacist information that you really weren't required to give the pharmacist, but it's good that you did. Because pharmacists are required to perform prospective drug use review before dispensing. So by knowing what that ICD-10 code was on that benzodiazepine and knowing what it was on the gabapentin provides more information for drug disease contraindication screening. So that's good, but I wanted to use that as an example because I didn't want any of you to admit where you transgressed the law that was a bad transgression.
They've been asking, though, the other thing, so I just started
Yeah.
doing it because I was getting
Been asked, yeah, I know. Well, that's the confused. See, that's part of the time we enact a new law, everybody's confused by it, and particularly one that is so technical like this one. So when you guys leave here today, you will be the experts on this new law and can help others understand it. Lack of mental health treatment. In the Tennessee Department of Health guidelines, it is recommended that if you have patients on concomitant benzodiazepine and opioid therapy, that you get at least annually a mental health consult as to the continuing use of that benzodiazepine. The problem is we don't have enough mental health providers in Tennessee to meet that need if everybody that is a chronic concomitant opioid and benzo user needed that consult. And in some places in our state, it's really a problem. Up in Tri-Cities, we were up there a couple weeks ago, it's a 6-month wait for a psychiatry appointment in Tri-Cities right now. Plus, due to an incident that occurred up there, psychiatrists are now refusing to prescribe any benzodiazepine therapy, and they're referring all the patients back to the PCP for that therapy. So that's that whole issue. Now I want to add one that's kind of related to that. If we believe that we had some patients in our practice that have kind of teetered away from substance use disorder into more addictive behavior, and we wanted to try to get them into an addiction treatment center, do we have enough capacity in our state for all those people? No, we don't. Even if we did, do they have health insurance? And even if they have health insurance, is that a covered service under their health insurance? Because quite often, substance abuse treatment is not covered under those general health insurance policies that most employers provide. Far right, undertreatment of pain. This is not the undertreatment that led to the Joint Commission creating the fifth vital sign and other things that were going on. This was the state of Tennessee being worried that when July 1 came, all of you guys would say, that's it, I quit. I am not going to prescribe opioids anymore. I'm tired of people telling me how to practice my profession, particularly a group of bankers and lawyers and insurance agents and farmers sitting down there in Nashville who think they know how to practice medicine, telling me I can only prescribe this and this and this. And in fact, I'll just send patients to the pharmacy, tell them to buy some Tylenol, some Motrin and some Aleve and take care of their own pain. Well, guess what? That did not happen, because once again, in our state, our practitioners stepped up and said, we'll take care of patients. That's what we're here for. We'll deal with this law, but we'll still take care of patients. We've not had that reaction in our state. One other issue I want to add that's not there, that these issues come out of Dr. Mutter's group in Nashville, and that is, can any of you think of a non-drug modality that you could use to help manage comprehensively chronic pain that the insurance companies won't pay for right now? Did I hear acupuncture? Acupuncture is one. Massage therapy, physical therapy. Some physical therapy is covered depending on circumstances. Anything else? What about cognitive behavioral therapy? What about yoga? You know, there's all kinds of stuff being talked about now. What about drug therapy that's not covered that might be beneficial? What about lidocaine patches, diclofenac patches, ketamine patches that are not covered? Okay? So I think a fourth issue in our state, and this is not unique to Tennessee, we really need to drive some health insurance payment reform. Because while they pay for a lot of the drug therapy, they won't pay for this non-drug therapy in a corresponding way. And in fact, what did we just hear out of I said that wrong, out of Blue Cross Blue Shield right here in Chattanooga a couple weeks ago? They're no longer going to pay for OxyContin. All right, so if you're going to take that off the table, what are you going to put on the table for us to use? So we'll talk about that as we go through the program. Dr. Mancini's got some components of his videos on multimodality therapy, and I'll mention some other things as well. So this under-treatment of pain, lack of mental health treatment, and inappropriate prescribing of opioids have been identified in Nashville as really major issues. We've identified a few more here this morning that I've added to this list. Contributors to the opioid crisis, pain is the fifth vital sign coming from Joint Commission. If you talk to CEOs of hospitals that were around back in the time when this went into effect, there was a lot of pressure put on CEOs to make sure that pain was being treated, and not so veiled threats about being put on probation and not getting accreditation and therefore losing Medicare funding and all these things. So it was a pretty heavy-handed tactic by Joint Commission. HCAP scores on patient satisfaction, and of course we know how the ED docs struggle with this sometimes, and patients complaining to the CEO of the hospital about they wouldn't give me my pain meds in the emergency department and all those issues that we know about. Not only did Joint Commission create the fifth vital sign, but they also put some pain management standards out there into the professions, and then insufficient collaboration among state prescription monitoring databases. That still is a problem here in Chattanooga, and not being able to get good data out of the Georgia database and accessing. So how do we deal with those things? People are working on those, but again, this opioid crisis is a multifaceted thing. It's not just one single thing that's caused it. Uh-oh. Before we proceed into talking about our laws in Tennessee and things, let's talk just a moment about medical malpractice. This is a study by Covaris. They looked at 10,000 closed claims from the period of 2012 to 2016. All of these claims are medication related. Okay, so the root cause of them is medication related therapy. They're not bad surgical outcomes. They're not failure to treat, failure to diagnose cases, none of that. They're all drug cases. First note, on the left you see that of the billions of prescriptions dispensed in our nation every year, 5% of them are opioids. So while the percentage is kind of small, the N on that is huge because it's 5% of billions. So keep that in mind. On the top right, opioids now account for 1/4 of the medication-related medical malpractice claims. So when you're writing an opioid prescription, think to yourself, okay, I'm writing a drug that has an attendant risk with it of a medical malpractice claim at 1/4 of those claims where the drug is the reason for the claim. By the way, what was number one prior to opioids becoming number one? Well, it's on the screen, anticoagulants. It could be, though, that the anticoagulants would have fallen out of first place even if the opioid crisis had not moved opioids to first place. Why might they have fallen out of first place? Because historically it was a single agent that caused all those claims, and that agent was warfarin. And so now we've got Pradaxa, Eliquis, Xarelto, other agents that are not creating that same risk of malpractice that warfarin did. But anticoagulants now follow us at number 2 at 14%. In those claims, they also looked at 15% of opioid-related claims, the physician allegedly behaved in an inappropriate way, including not saying no to persuasive patients, not reviewing changes in clinical status, and renewed prescriptions without monitoring patients. It's this type of background that caused us in Tennessee, and I recognize that, well, who all was from outside of Tennessee, came here from residency from outside of Tennessee? Okay, good number of hands going up. So as we go through today, I'll try to give you some things about Tennessee law that may be of interest and help to you. In our state, because of this background, a prescription for a maintenance medication for a chronic disease state like antihypertensive, oral antidiabetic prescriptions valid for 1 year from the date of issuance. And you'll know that year's up because the pharmacist is going to call you and say, Miss Jones is here for her Tenolol and Metformin, but I can't fill them because the prescription's more than a year old. And you or somebody in your practice might say, well, go ahead and give her another refill and tell her to come in. We need to see her. 30 days later, what happens? Same phone call. 30 days after that, same phone call. Same phone call. And so that's problematic, one, because of this kind of data showing that failure to monitor clinical status puts you at risk of medical malpractice. So it's good to get them back into the office, but you also lose a billable encounter. Not that I'm trying to drive up the cost of health care in our nation. That we do that already, but thinking about that as a billable encounter and getting that patient into the office, we achieve multiple purposes. I'm not sure what is happening with the clicker. Kudos to you guys. This is national data. In 2000, you see that 12 to 15% of all claims were for medication-related claims. So that's a pretty high number if you think about all the procedures that are done and all the things. That's still a pretty high number. But by 2017, that had dropped to 8%. So you guys are bringing a new level of safety to managing medications and prescribing drug therapy. Oversupply concerns. 68% of people who are using non-medically obtained pain relievers got them from friend or relative. That'll become a theme throughout our program today. Teenagers who want to get high from using a prescription drug tell us they can obtain that prescription drug within 1 hour of deciding they want to get high using a prescription drug. That's how available these things are out there in the community. And then according to the Children's Defense Fund, 205% increase between 97 and 12 in toddler and 1 to 4 years of age poisonings with opioids. So we all need to message to our patients about making sure medicines are kept out of reach of children. This is not so good data in Tennessee. In the 4-year period from 2012 to 2016, the number of deaths due to combined opioid and benzodiazepine therapy doubled from 4 per 100,000 to 8 per 100,000. And now we see benzodiazepines as being present in 35% of all overdose deaths. Well, let's hear from Dr. Mancini about consequences of opioid therapy.
Now, we're all aiming to provide better care for our patients. And so realizing the consequences of opioids makes us reconsider how we employ opioids in our care. Well, how can we do something different, right? Well, one of the concepts to think about is that opioids just don't start with surgery, right? Our patients will have surgery, they'll get pain either in the hospital or at home, but then there's that prescription that's given. Now, we often write prescriptions for the patient's convenience and ours. And the reality is that a lot of our patients, they fill their prescriptions, but they may never use all of their pills. And actually, this has a major impact on our society. There's unused pills sitting in medicine cabinets. Oftentimes, they are used, but they're not used for the right reason. They're used by other patients, or they're looking at other family members that are using them in the wrong way. So the impact is not just for our patients, but it's those loose opioid pills that are still out there that have a major impact on that addiction problem. We also need to always consider when we're writing that prescription is what are going to be the adverse outcomes that are happening because of the opioid that's going to be there. Are patients going to be back in the emergency room? Are they going to have more constipation issues? Are they going to be calling for nausea medicine or anti-itching medicine that simply adds to the list of pharmacy and medications they're taking? If we start considering the negative results that happen from our opioid prescriptions, we'll see opioids not as our first line, but as an adjunct only when other things fail. Now, finally, if we think about multimodality strategies, putting together pathways, whether outpatient or inpatient, to use medications that are compatible with the patient's condition, using them together in concert, oftentimes we can reduce the amount of opioids someone needs to use or even eliminate it altogether.
Oops. Have more good news in Tennessee. CSMD, the Controlled Substances Management Database, was checked in 50% of prescriptions for opioid and benzodiazepine therapy. Now, you might think, well, why wasn't that 100%? Well, remember the mandate in Tennessee is if it's a greater than a 7-day course of therapy, you were required to check the database and then annually thereafter as long as that therapy was continued. So we would not have expected it to be 100%, but it would have been nice if it was 80, 85%, because that might have told us that even where you were prescribing less than 7 days, you were sometimes in there checking the database. Doctor shopping's down 76%. I think that's because you're in the database and you're identifying individuals that are doctor shopping and you're refusing to prescribe the drug. The third one and the last one I want to talk about at the same time. Opioid prescriptions are down 15% and 22% decrease in MME from 12 to 16. I think in Tennessee you've heard the messaging from the Department of Health. The first part of that messaging is that with MME, once you are at 120 MME, you have a 13 times greater risk of a fatal overdose. In the guidelines on chronic pain management in Tennessee from the Department of Health, they tell you when you hit 120, there are things you have to do. So the first time the patient gets to 120 MMEs, you are supposed to call and get a pain management consult. When you are at 120 MMEs for 6 months, then you are supposed to get an in the presence of visit of your patient over to a pain management specialist. And so I think what you've done is you've heard those messages and you've gotten the MME down from 120 to avoid having to engage in those activities. But at the same time protecting the patients against those fatal overdoses when we get to 120. So that's all good that that has happened. Benzodiazepine prescriptions are down 11%. I think that's indicated as being due to the increasing literature about concomitant therapy with opioids. But there also is the issue of clinical adversity in patients that are elderly who are on chronic benzodiazepine therapy. But we still have prescribing challenges. Many healthcare providers don't receive extensive education in school about prescribing controlled substances. This is a good point for me to ask, where are the allopathic physicians in the room, the MD group? Where are you guys at? Okay. And where's the osteopathic group? Okay, so we've got a couple. Great. All right. So I want you to close your eyes and drift back and think about the M1, M2, DO1, DO2 years and how much pain management you received in those curricula. Very little, none. Well, there was a physician up in Tri-Cities the other day, and I won't say what medical school he went to. He and his partner came up after the program and said, well, where our medical school, we had a 2 full-day symposia on pain management that was mandated that we go to it. I said, oh, that's great. He said, no, actually it wasn't. It was sponsored by a drug company, and they told us how little risk opioids presented and all that. I said, bad program. Don't listen to that. So I don't know what you got if you got something of any significance. The substance abuse section of NIH recently conducted a survey of medical schools. 3 hours is the average amount of time spent in the first 2 didactic years of the medical school curriculum. So what that tells us is young physician students and even residents learn about managing pain from preceptors and attendings and program directors and all that. So as you finish residency and engage and enter into practice, I would hope that you would think about being a preceptor, because obviously the academic programs cannot deliver those degree programs unless you guys are out there taking students on rotation. So it's a tremendously valuable service that is provided by the practitioner community in our state. Practices lack protocols to support providers in properly treating pain, short appointment windows. Who's prescribed more than a 3-day opioid supply since July 1? All right, so what did you have to do that prior to July 1 you didn't have to do? In writing from the patient, a what? Informed consent. So how much time does that add? So if you're already squeezed on the amount of time you've got in that appointment window, now you've got to squeeze in some more activity in that same period of time. We'll talk more about that when we talk about informed consent in a few moments. Lack of diagnostic tools or follow-up on referrals. Lack of protocols surrounding preventive measures such as urine screens. Consumers expect prescriptions. We know that that was a problem with antibiotics, and now we have the superbugs, antibiotic resistance, stewardship committees in hospitals, medical. That's created a lot of fallout. We also know that happens in certain places with opioids, emergency departments being one of those, of course. Healthcare providers often dislike confrontation. Any pediatrics folks in the room? Where are the pediatrics practitioners? Okay. All right, so what kind of confrontational conversations do you guys get to have? Because you get to have a lot of these, not always with the patient, but with the parents. What was today? Don't give us any patient names or anything. We don't want to have a HIPAA problem. Opioid-containing pain med for an 18-month child. Okay. What else? What about vaccines? Either infantile or adolescent with HPV, refusing those. What about they got a head cold, you think, or a virus, they want an antibiotic, right? Okay, what else? What about your stimulant use? What about adolescent ADD? So mom or dad bring the child in, you've started doing urine screens as part of some protocol, and the urine is clean. And I don't mean clean as to illicit substances, I mean clean as to anything in that urine. What do? Well, Mr. and Miss Jones, is Johnny taking his medicine? Oh, yeah, Doc, he's taking it. I make sure he takes it. In fact, even the school nurse administers it to him during the day while they're in school. Well, I don't understand why there's nothing in this urine showing me that he's taking his medicine. Well, you're the doctor, you figure it out. Okay, I will. And here's how we're going to figure it out. You have that Damascus Road meeting with mom and dad, right? And you say, I'm going to start doing monthly urine screens, and if I don't see something in this urine, I'm going to stop the stimulant therapy. And in fact, you have to stop it. Why? Because federal law says you can only prescribe a controlled substance for a legitimate medical purpose. If there's no no drug in that urine, you don't have any legitimate medical purpose anymore. Why? Because you're not getting any medical outcome. You're not getting any therapeutic outcome. Mom and dad, something's happening to it. We don't know what. By the way, so you think, okay, if I go to the database and mom and dad are getting the Tennessee triple cocktail of hydrocodone, soma, and Xanax, that'll be predictive that they are a substance user, and that probably tells me what's happening in the stimulant. Can you go check the CSMD on mom and dad? No, because they are not your patients. So don't fall into that being a detective kind of approach and going in that database for purposes other than managing your patient. Well, I picked on the pediatrics practitioners, but here's one that all of you can have some confrontation with, and that is who's tried to taper patients off of opioids or benzodiazepines? Okay, a few hands going. How's that gone for you? But I always ask, have you had any success? Yeah, everybody's had some success. I think as I've talked to physicians around the state doing these programs this year, I think that while in medical school, but primarily in rotations and in residency, you learn how to have difficult conversations with patients, particularly over the death of someone that did not survive the heart attack and the ED or whatever it may be. You get that through practice and exposure, but you don't have as much of that about what to do about controlled substance therapy. Sometimes that's more of an irate, angry discussion than it is trying to get somebody to stop the therapy. I had a physician that kind of confirmed that in my mind the other day in a program we were doing. I was up in Tri-Cities. No, wait, this one was over in Columbia, Tennessee at Maury Regional Hospital. She said that I realized that I was too dictatorial in my approach. She gets a lot of referrals of patients because of the nature of her practice. A lot of those patients who are referred to her are already on opioids and benzodiazepines. And she would show the patients the data about risk of overdose on that concomitant therapy. And then she would say, we're going to stop this benzodiazepine. I'm not going to continue it. And here's the plan. We're going to taper off of it. And I'd get pushback from patients about that. And one day she thought about it and said, maybe I need to be more engaged with the patients. And so what she started doing is she would still show them the data, and then she would say, I'm going to let you pick which of the two drugs you want to taper from. And she said immediately the pushback stopped, because now they felt more power and control in that relationship with me, and I let them choose, and my success rate went up. She said not everybody successfully tapered, and I also will admit that sometimes about 4 weeks into the taper protocol, I'd get a call from the patient, and the patient would say, Doctor, can I change my mind? I think I'd rather taper off the other drug. Sure, that's fine. If you want to try that, that's fine. I'll work with you. So think about that. Now, there is a series of videos that you can Google, Dr. Lemke, difficult conversation. If you'll just type that into your browser, they'll come up. Dr. Lemke, difficult conversations. And they are these little videos that she's put together, and they are stick figures. There's a chair, two chairs facing each other. You'll be able to tell which one's the physician because that stick figure has on a white coat. But it's guidance on how to have that difficult conversation. I don't know that we've spent enough time in medical education working on that issue. We'll come back to some of those conversations in a few moments, okay? On our next slide, Dr. Mancini is not any different than everyone else. He too has had conflict with patients and difficult or confrontational issues. So let's hear about his personal story. Uh-oh. This was working fine earlier today. Here we go.
So I want to talk to you today a little bit about how I got here, because this was not the most common place that I thought I would end up. So I'm a general surgeon. I practice every day, and I prescribe opioids to my patients. It's been a long stay treatment for our patients. So when we do surgery, we know that we're going to cause pain, and we have over time prescribed more and more opioids. Well, I did something special. I went to do a fellowship, and my fellowship was in minimally invasive surgery. And the whole concept of that was to do less trauma and injury to the patients. Doing little keyhole surgeries, we thought we would do our patients better. Now our patients did do better, but over that time period, over the last decade, even in my practice, we really saw the number of prescriptions prescribed really rise. And then, like a lot of things that happen in our practice, we may have one patient experience that really makes us look at ourselves. And so let me tell you a little bit about that story. I had a patient who was a friend of mine who developed pancreatitis. And that pancreatitis was an acute issue. We treated him as we usually do, and pain medicines are often prescribed with regards to pancreatitis. But in his bad disease, his acute pancreatitis became chronic pancreatitis. And I treated him for about a year through surgeries and care. I had one moment in which I was called to the floor to see the patient, a friend of mine, who was struggling with this disease for about a year. And the nurses were upset because they couldn't control his pain, and they needed finally to see the attending physician, and that was me. So I went in to see my friend, my patient, who I've been taking care of for a year, and he was irate, upset about how his pain was being taken care of. But as I looked into his eyes, I realized that I wasn't recognizing that same person. I was looking at a person who was addicted to pain medication. And a lot of the suffering that he was dealing with were actually withdrawal symptoms. So when I left that room, I realized that no, I didn't give this person pancreatitis, but in that care, I had changed that patient's relationship with me and with pain medicine.
And so with some of our people in Tennessee, risk begins very early. In fact, it begins in utero for some of those people. So let's talk about NAS for just a moment. The good news is in Tennessee, we have not had a major spike in the last 3.5 years. So if we look at 15 through this point in 18 data, we see that the number of cases overlays from year to year. The lines are pretty parallel there. They overlap each other quite closely. I don't know that we're going to see a downturn in NAS cases in my lifetime. And I'll explain why that is in just a moment. So on the next, wow, this thing worked perfectly fine this morning. Okay, so when we look at the case reports in Tennessee, we realize that there is a cultural phenomena, and it's supported by this data. Look at the very bottom. West is 2.5% of the cases. Upper Cumberland, right above that, is 12.2. If you go on up the chart in the midpoint, 12.2 in the mid-Cumberland. So for those of you not from Tennessee, if you leave Nashville and drive toward Knoxville and Tri-Cities, you go up the plateau, as it's called, into Cookeville. So beginning around Cookeville on the Cumberland Plateau and then moving east, the numbers skyrocket. Look at east at the very top, 22.5%. Down here in Chattanooga, Hamilton County, you'll be interested to know only 3.2%. So you guys are south of that Appalachia influence. Now, many of you that are residents were still in elementary school when OxyContin hit the market. But have you heard what the street slang was when it was first crushed, dissolved, and injected? Hillbilly heroin. In that Appalachia culture of Upper East Tennessee, Eastern Kentucky, Southwest corner of Virginia, Eastern West Virginia, you've got a substance use culture up there that's quite phenomenal. And there are people that are working to try to address that, ETSU being part of that with a grant that they have received. But we now know that there are three-generation families. You've got the grandmother, the daughter of the grandmother, and the daughter of the daughter, all three generations addicted to opioids. Now, there's a lot of genetic work being done at lots of places. Medical College of Virginia is one of those places that is showing the genetic connection to that multi-generational addiction to opioids. The other thing that's coming out of some of the MCV research is the potential for a test that is genetic-based that you could administer to a patient that would tell you if you give that patient an opioid, they're going to become an addict to that opioid drug therapy. That would be a phenomenal thing to have in your toolkit for identification of those patients. So until we break that substance use disorder culture, these cases are not going to decline. And the problem that that's led to is on the next slide, and that is, look at what is the number one source of exposure now, medication-assisted treatment. Because all of these young women in that Appalachia culture are into that substance use culture. They are using, they become pregnant, and so you have to treat. So we've got to stop that substance use culture. By the way, shout out to the OBs up in that area of our state that have learned how to manage these patients, because you can't allow them to continue using illicitly while they're pregnant. You've got to manage that condition, which is why MAT now is the number one source of exposure. But in a general daily practice of medicine, you guys are not responsible for this. Look at legal prescription of an opioid, 6.8, legal prescription of a non-opioid, 7.9. So that's a small percentage of the cases. Now, I would say in the fourth item down, if you're like the doctor in Florida that's writing a quantity of an opioid on a prescription to give somebody 100 oxycodone a day, you're probably contributing to that fourth one because they've got a lot of opioid in the community with those kinds of numbers, and that's where they're getting that. So that's a pretty significant number as well. So the percentages are pretty much based on the medication-assisted treatment and people getting access. Our pediatrics practitioners, pick on them once again. You guys are reading about adverse childhood experiences, right? And how that has predictive value as to adult behavior. So more likely to report chronic pain that interferes with activities of daily living, likely to seek opioids, displace antisocial behavior, and also to involve more injectable drug use. So the question I ask sometimes in programs is, do you ask a patient on initial interview, if they've had adverse childhood experiences? And I'll see heads go, no, and I'll see other heads go, yeah. And typically, if you explore that, the yeses are the pediatricians and neurologists that are treating adolescents with social behavioral disorders. You know, the child that set the cat on fire in the neighborhood, that's maybe a place to ask that question. I had to take my 92-year-old mother in Morristown to the dermatologist the other day. Squamous cell carcinoma it came out of nowhere in a couple of months. And so we're undergoing treatment for that. But is that where you're going to ask about adverse childhood? Of course not. She's got dementia. She's not going to remember anyway. But it's not relevant and probative of treatment of that condition. So, but think about that. And the other thing to think about is in the middle column and the left column, you think about those types of abuse because you know in Tennessee it's mandatory that you report known or suspected child abuse, which is defined as abuse, brutality, and neglect, and child sexual abuse, which is defined as the commission of a sex crime against a minor. Those are mandatory reports. So you file the report either with the Department of Children's Services, with the sheriff of the county, the police chief in a municipality, or the juvenile court for the county. Now, by the way, if a child is brought to you from Meigs County or Bradley County down here to this great medical center and you suspect child abuse, do you file that report here in Hamilton County or in Meigs or Bradley County where the child resides? Meigs and Bradley County. So the report goes to the county where the child resides. Now, on the right are things that you don't think about in those reports, but they're making their way into the literature now as being predictors of childhood, from these childhood consequences in adulthood. Mental illness, incarcerated relative, mother treated violently, substance abuse, and divorce. So when you see behavioral issues in adults, maybe there is some tie in your patient to those things, and you might know about those just from patient conversations. So screening tools. One of the things that we are hearing from specialists is that, and particularly mental health and pain management specialists, in an era of paper records, you could not build depth because the charts just got to be unmanageable. But we're in an EMR world now. And so what the specialists are asking is that the depth of data and the length of the building of that depth of data increases. So in other words, if you're going to get a consult from a medical professional, either in mental health or in pain management, the deeper the data set in that medical record, the better they can do an evaluation. And particularly if they want to do longitudinal review, they need that depth of data. So that's what I'm hearing them ask PCPs and others, is to build that depth of data. And I'll mention that again in interprofessional team care in a little while. So screening, brief intervention, and referral to treatment in the SBIRT, the cage aid assessment. Now, if you've looked at the Bureau of TennCare, they've created a form which marries together the SBIRT and the cage aid into a single document. So that might be something that you could use in practice. The DAST-10, the Drug Abuse Use Questionnaire, is another example. So again, how can we build more of this data into our records? The other one is something like the Barthel Index of Daily Living, so that you are looking at functionality and how important that is in Medicare patients. And we'll come back to that in a little while as well. So let's now talk about some Tennessee and federal law reminders and updates. And the first one I want to talk about is this. Originally we weren't going to put this in the program this year, but then we decided to. I get calls, SVMIC gets calls from physicians and others, and they'll say, I read something from the Department of Health, and it talked about a collaborating physician. What is a is that a consultant? What does that mean? The collaborating physician is the new language for the old language of supervising physician. So when we first created certified nurse practitioners in Tennessee decades ago, we created this thing called a supervising physician. The legislature revised that language, and it's now a collaborating physician. So while we're talking about this, because there's another potential change I want to mention related to this, remember that the collaborating physician or substitute must be available for consultation at all times, must be in the same area of practice. So a cardiologist cannot be collaborating physician to an OBGYN, APRN, or PAC. Need to have your formulary and protocols to set the scope of practice. Review 100% of patient records if a controlled substance is issued 10 days to review, certified by signature, and 30. Now, for non-controlled, remember, you randomly select 20% of the patient records you want to review in association with that prescribed non-controlled substance. Far right box, that's the other reason we wanted to mention this. This law is antiquated because when the law was written, it was required that you sign off on charts, and the problem was all those charts were paper. This was written back in the 80s. So you had to go out to any remote sites and put ink to paper to sign off on those charts. You don't do that anymore. You do that review of those records online in that EMR platform. There's no need to go back out there every 30 days. So the medical board is in the process of considering removal of this from the law because it's still in there right now, but the utility of it is no longer present since everything's an EMR portal. Well, that gets us to the focus of the next few minutes, and that is our new law in Tennessee on prescribing opioids. So if you would, find the schematic, because we're going to work from this for the next few minutes instead of the PowerPoint. Everybody have it? So you can make notes on it as we go through. Okay, so let's start out by reminding you that this new law applies only to the opioid class of drug products, nothing else. Top left green box, up to a 3-day opioid RX, max dosage of 180 MMEs or 60 MME per day. Nothing additional is required. Practice good medicine and move forward. I will come back to this point on another new law, but that threshold or limit of 180 MME, I would encourage you to stick very closely to that. And I'll show you why in a few moments. So then when we talk about a 4-day to a 10-day opioid prescription, now you've got a max at 10 days of 500 MMEs or 50 MMEs per day. And you must put the ICD-10 code of the primary condition you're treating on the prescription. So what if you wanted to write a 5-day opioid prescription? What would be the MME max for that 5-day course of therapy? Be 250 MMEs. You take the daily value and multiply it by 6, if that's how many days therapy you're writing, to come up with the maximum MME for that prescription, the total. Does that make sense to everybody? Okay. So 4 to 10 days, 50 MMEs per day. If you have to calculate, you have to put the ICD-10 code on the prescription. And you've got to comply with the things in the orange box. So let's talk about those. The first is the informed consent requirement. Risk of dependency, addiction, and diversion, expectations and how to use, condition-specific alternatives, and information on neonatal abstinence syndrome and accessing contraceptives if you're 15 to 44 years of age and female. Now, I don't know what informed consent form your residency programs pulled and are using, but if they pulled the one off of the guidelines on chronic pain management in Tennessee, that one's not effective because it doesn't have the NAS and contraceptive information in it. So what I would encourage you to do on the back side of this, you see in this FAQ, SVMIC has an informed consent document online. What I might encourage you to do is take the one you're using, pull this one from SVMIC, and do a compare and contrast and just see what the differences are and look at adding what may be in the SVMIC, but particularly making sure that NAS and contraceptive use is covered. We go over to the right I'm sorry. So let's talk about informed consent for just a moment. If you obtained it, you had to do it in writing and signed by the patient. So when you left the encounter room with that informed consent piece of paper, what did you do with it? You had to do a handoff, right? So either a handoff to the staff, or the other reason I told you the story about the mother going to the dermatologist is I was standing there at the checkout window paying for the copay. I looked up and I saw on the wall this file folder box stuck to the wall, to be scanned, written on the front of it, and had all this paper in it. So there's the first opportunity for that informed consent document to be lost, right? Second opportunity, somebody's going to take it out of that folder, make a .pdf of it, and then it's going to sit out here somewhere in that electronic platform until somebody goes and retrieves it and then makes it an attachment to the EMR, right? Which is the third point. It could get lost because it could get attached to the wrong EMR record. So what I see some physicians doing that I talk to regularly is they're putting that informed consent into their EMR as an electronic document. Another way to say that is most of you go into the encounter room not with a paper chart, right? You go in with a device, either a laptop or a tablet. And so sitting over here on the side are these forms. And there's that informed consent because you're going to prescribe an opioid. You tap the right place and in comes that form into your EMR. So then you sit down and you show Ms. Jones on your electronic record system, you show her that informed consent. And then when you're done, you turn the tablet and you hand it to her and say, now would you take your finger and sign down here at the bottom of this device? You've immediately captured it into that EMR record. You reduce the risk of it being lost because you don't want to be able to have to defend against not having that informed consent in the record. So that may be helpful to you. It also saves some staff time in having to do all that work that I just described. Now, we all think about informed consent as documenting something that we were required to do, and that makes sense, and that's what you're required to do here. However, I would encourage you to think about it as a teaching tool or educational tool for patients. So Ms. Jones comes in for her regular visit. She's an RA patient, got degenerative spinal arthritis. She's been pretty well controlled without opioids over the years, but in the last few months she's really had a lot of back pain. And you've tried some other adjuvant therapy, maybe non-drug therapy. But today she says she was talking to her friend at church on Sunday. She has the same thing I have, and her doctor gives her tramadol. And I'd like to have tramadol. Well, I think there's an opportunity to use the informed consent as a teaching tool. Now, I say that with this background. In Tennessee for years, one of the discussions that we would regularly have is how do you dose an opiate in an opiate-naive patient for safety and efficacy? How do you manage that dosing and that initiation of that therapy? That's no longer the conversation in Tennessee. The conversation now is how do I keep an opiate-naive patient opiate-naive? That's the message Nashville is speaking, is don't initiate opioid therapy. Dr. Mancini's already said that. He'll say it again in a later video clip. So how do we manage that? So what if you took the informed consent document and said, okay, now that you've asked me about that, let me tell you about some things about opioids, and use that document to teach her about opioids. And then you can say, I'd really like to try something else before we go that route. Let me try whatever you can think of to keep her opiate naive. So think about that use of your informed consent document. Let's go to the right side of the orange box. Check the CSMD. We'll talk about that in a moment. Conduct a thorough evaluation of the patient. Well, obviously you would do that. Document consideration of alternative treatments for pain and why an opioid was used. That is not intended to be a laborious note in the record or some complex note. So you decide for this patient, well, yeah, I've looked at your scans. Tramadol makes sense, so, I'll go ahead and try that. Well, you don't need to worry too much there about it because you've already had her on non-opioid therapy, but you might just make a note that progression of disease is to the point where I can't control it with NSAIDs or COX-2 inhibitors or whatever. But what about an opiate-naive patient? There, the conversation and note is simply looked at patient's medical record, a long history of gastric ulcer disease contraindicating NSAID therapy. Or I recently did some testing of Ms. Jones, and based on this creatinine level, we're not going to be giving her an NSAID. It's contraindicated. That's all that's required, just a simple note like that, and then try your opioid therapy. The next item down, include the ICD-10 code in the chart and on the RX. Now keep in mind that sometimes a staff member might be who's writing the ICD-10 code on your script for you, pulling it out of the medical record, okay? So what if you get a call from a pharmacist, and this has already happened in our state, and the pharmacist says, Doc, I know you're busy, and I'm sorry to bother you. However, this ICD-10 code makes no sense related to this drug therapy and based on all that I know about this patient, because she's been a patient of mine for many years, and you pull the record and you say, well, the reason it doesn't make any sense is because it's the wrong ICD-10 code. Okay, great. Well, let me get you the right code, and you give the pharmacist the right code. make sure you go back to the medical record and change that code in the medical record so you've got consistency, so that if there's a prescription audit at a pharmacy and questions begin to arise, at least there's consistency between the chart and the prescription. Now, there's a third place, though, in the medical practice where that ICD-10 code is important, and where is that? All of you have an office that does this for you, billing. Okay, so the claim submission, what code was used on it, making sure we reconcile that claim if we have to change the code that was submitted. And it may be that it's right in the chart and it's right in the claim. It was just when it was transposed to somehow they got the wrong code number. Look at the next item down. There's a star by this one to remind us that this does not go in effect until January 1. But beginning January 1, on prescriptions that are 10 or more days of therapy, the pharmacy will only dispense half of the quantity. And the purpose for that is to avoid all this unused opioid laying around in people's homes. You'll know that law has gone into effect because you'll hear in the local news about how an irate patient jumped across the pharmacy counter and beat the crap out of their pharmacist, right? That's how you'll know this law is now into effect. We'll talk about that in a moment in a hypothetical, but that partial filling begins at a 10-day prescription. So in other words, if you write a 5-day opioid, the pharmacist isn't going to give them 2.5 days. That half fill begins at 10 days. So, if you're not writing that many 10-day prescriptions, it really won't affect your patients that much. Okay, then we go to the gray box below the orange box, and from 11 days to 20 days, we see the numbers there, we see the ICD-10 code, and then we see the word surgery. This was intended for post-surgical discharge prescriptions. So typically a 10 to maybe 14-day supply or even 20-day supply for post-surgical patients. Let me clarify, though, you don't have to limit this to a post-surgical discharge patient. A 20-day prescription could be written for anybody, but they created this surgical thing for, as you see, more than a minimally invasive procedure. And then to the far right, only after a documented trial, failure, or contraindication of a non-opioid treatment, then you get up to your 30-day opioid prescription. And then you have to add, in addition to the ICD-10 code, the words medical necessity. Notice that as the day's supply increases, what happens to the daily MME value? Goes down. And that's to keep that 120 MME thing in your mind as you're prescribing these drugs. So my PCP, who's a DO in Maryville, Tennessee, was at a program we had done for his group in maybe early June. Just so happened my annual physical was scheduled for the third week of July. So when he came in the room, I said, "Well, Doc, how's it going?" And we kind of chuckled, and he said, "It hasn't been that bad. If I've got somebody with a strain or a sprain that I think a couple of days of opioid is justified, I'll write a no more than 3-day supply. And most of my chronic opioid users have met one of the exemptions, and that's made it a little less burdensome." And so let's talk about the exemptions, and that's what's in the light gray box down at the bottom of your document. So the first thing I want to note is if you have an exemption present, you must, of course, put the ICD-10 code if you're more than 4 days, but you also write the word exempt on the prescription. So let's talk about these. The first one is treated for chronic pain with an opioid for 90-plus days in the last year. What is the basis for that exemption? Does anybody think about that? The Tennessee Department of Health guidelines on chronic pain management refer to and define chronic pain management as, guess what, 90-plus days of opioid therapy in the last 12 months. So once you go to the database and you see that your patient has had 90 days of opioid therapy in the past 12 months, put this document to the side. And then go pick up the Tennessee Department of Health guidelines on chronic pain management, because that becomes the more relevant document in guiding you in managing that patient's chronic pain. This was designed for what? Acute pain treatment in opiate-naive patients. That's what this is really targeted toward. So once you hit 90 days, go pick up the Tennessee Department of Health guidelines, and we'll highlight a few of those guidelines in just a little while. The next one, active or palliative cancer treatment. Well, that's a great addition because under the guidelines, you had hospice was an exemption under the guidelines, but not all cancer patients that require pain management are enrolled in hospice, right? So that's good that that was added. Hospice care is the next one down. The next one is new, sickle cell disease, chronic condition, as you know, painful episodes, so they get a lot of chronic opioid therapy. Seeing a pain management specialist and being treated for substance use disorder, well, again, because of who's treating and how that's being managed, that's exempt. Severe burns or major physical trauma. Now, the legislature did not define those in the new law. However, what they did do is assign to the CSMD Task Force Committee to write those definitions. That happened on October 2nd. We'll look at those in a moment. And then patients in a licensed facility. Remember in Tennessee, we license facilities under two different bodies of law. One is the health care law, so that's your acute care hospital, your SNF, your LTCF, assisted living, etc. Under the mental health laws, we license, like, for example, inpatient psychiatric hospitals. You've got a great one right here in your community known as Moccasin Bend. So in either, doesn't matter which body of law, in those health care provider facilities, those patients are exempt. So what does exempt mean? Exempt means that you can avoid some of these things, but not necessarily all these things. So let's use an example. Newly diagnosed sickle cell patient. They're exempt, right? Yeah, but you still need to do all this initial informed consent and all that to build that record. But if you have a patient that has been a patient and they're a sickle cell patient, and now you're going to add opioid therapy because now the status of their disease is causing pain, they're exempt. See, they're already diagnosed. You still need to do the informed consent that initial time. But after that, once they're started, if they discontinue the opioid, they start back, then they're always going to be exempt after that initial treatment with the opioid. Now let's talk about the, I'm trying to think, with the sickle cell does not make a good example for this next piece. Let's go on to the back of the document. And yes, sir. I'm going to give you that definition in just a minute because they wrote it this week. Let's finish this and then we'll go back to the slides. So top left, yeah, that's why I'm changing this around a little bit today because now that we have some other new information that just came out, affected our program, how we deliver it this week. So at the top left, I need to remind you about something that not a lot of folks remember from this new law. In the law, it says that a patient may not be treated more than once in 10 days with an opioid. Now, why did the legislature write that into the law? Because they knew that what some practitioners would do is write a 3-day opioid prescription to avoid all of this. Then they'd write another 3-day opioid prescription, and then another 3-day opioid prescription, and then another 3-day opioid prescription. And the law was written to prevent that from occurring. So that's why the law says a patient may be treated only once in 10 days with an opioid. There's one exception to writing another opioid in that 10-day window, and that's what this upper left corner is about. The only exception is you have an adverse reaction to the initially prescribed opioid. And when that happens, you can change your opioid in that 10 days, but you have to meet these requirements. So let's talk about what these are. First one is the healthcare practitioner is employed by the same practice that initially treated the patient with the opioid that caused the adverse reaction. So you're a surgeon, you performed some procedure on a patient, and you wrote a 10-day prescription. And let's jump ahead for a moment. It's now January 4th. So on January 4th, you discharge 10-day prescription for opioids. Day and a half later, your surgical patient is calling me the patient's PCP. And they're saying, my surgeon gave me this drug when I left the hospital, and I can't take it. It is tearing me. I am throwing up. I feel horrible. I need something else. Can I, as the PCP, help that patient? Maybe, maybe not. What's the first question that has to be answered? Do we work in the same practice? So a couple weeks ago, we were at State of Franklin Healthcare Associates up in Tri-Cities, and they've got multi-specialty practices. They've got surgery, OB, they've got general internal medicine, family medicine. So yeah, there you could probably manage that as the PCP. But if you are a surgical group and you stand alone, no, it's going to have to come back to either you or another surgeon in that group to deal with this situation. The next item, evaluate the patient. Well, that makes sense. I don't need to talk about that. Third bullet, the healthcare practitioner confirms with the dispenser that the remainder of the initial prescription has been canceled by the dispenser. So what you're going to need to do is say, Ms. Jones, where did you have, remember we're a day and a half into the therapy, okay? They got 5 days at the pharmacy. We've still got 5 days hanging around out here. So you've got to say, where did you have this prescription filled? And maybe she's got the vial. She holds the vial up. You take it. You have to call the pharmacy and say, do not dispense that remaining 5 days because I'm changing the opioid. So maybe you had the patient initially on hydrocodone and you think that maybe tapentadol or tramadol may have a lower nausea profile in that patient for whatever reason. Call the pharmacy and say, do not dispense the remaining 5 days. And sometimes I'm asked, well, can't I just write a note on the prescription to the pharmacist? Well, yeah, you could, except the patient, how do you know they're going to take it to the same pharmacy? So you've got to call that dispensing pharmacy. So if you dosed it 1 every 6 hours, that would be 4 dosage units a day. The pharmacy gave her 5 days, so she had 20, right? So she's probably taken 6, means she has 14 left in her vial. So now what you do in the fourth bullet is you say you need to dispose of those remaining tablets. Again, we're trying to get loose opioids laying around people's homes disposed of so that no one can get access to them. Think about that for just a moment, though. If we did not do the half fills, instead of having 14, she'd have 34 opioid tablets at home that she's not going to use. So it is effective in reducing the amount of opioid that is available. So then you decide to, and I'll talk about disposal in just a second. So then you decide that you are going to give a different opioid. Now you go back to the front and kind of start all over and consider the things on the front. Well, I've now told you what are the partial fill requirements. I've told you why we're doing that, to reduce unused opioids. What's meant by major physical trauma, I'll define that in a moment. What are the changes to requirements for checking the CSMD? Now, just for this little section, we're going to talk about opioids and benzodiazepines because there's another law that mandated that more than a 7-day supply of an opioid or benzo, you had to check it and then annually thereafter. So now with both opioids and benzodiazepines, once you go past 3 days, you have to check the database on both of those drugs, opioids and benzodiazepines. And then you have to check it twice a year instead of once a year. So if it's chronic opioid or benzotherapy, it's now a twice a year check, not just once a year. So that's the first new wrinkle in that law. 2 times a year to check the database. Here's the next wrinkle, the first bullet you see there. What is a new episode of treatment? A new episode of treatment is defined in the law now as being no opioid or benzodiazepine therapy in the last 6 months. So think about a total joint doc who has a patient that we're going to do a total joint, but has had bone-on-bone pain for a few months, so we've got them on an opioid while trying to schedule them in for surgery. They come in for surgery. On discharge, let's say the hospitalist is writing orders. Is that a new episode of treatment to the hospitalist? No, because they were already on an opioid within the last 6 months. So it was a new episode of treatment to the surgeon when the surgeon saw them in the practice and decided to go ahead and treat with opioids until we get them into surgery. Makes sense? So think through about that if there's no opioid or benzo in that database, CSMD, it's a new episode of treatment, if none in the last 6 months. Now here's the other new wrinkle. So my total joint doc does the surgery, writes a 10-day opioid prescription on discharge. 9 days after discharge, we've got some complications and continuing pain. So on day 9, surgeon says, I'm going to have to write another 5 days of opioids. Does the surgeon have to check the database again? Yes, because that's what the second bullet says. In a new episode of treatment, every time you write an opioid or a benzodiazepine in that first 90-day window of that episode of treatment, you have to check the database. So if you're writing weekly prescriptions for somebody, just because you want to manage how much they're receiving, every time you write that prescription, you got to check the database for that first 90 days of therapy. It may result in people writing larger prescriptions than, yeah, it may. It very well may. So remember that upper right corner applies to both opioids and benzodiazepines. I've already mentioned that SVMIC has a sample opioid consent form. Now this next question, there are 2 asterisks after it because SVMIC and I want to make sure you know we did not write this answer to this question. What is meant by more than minimally invasive surgery? Major surgery is more than minimally invasive. Minor surgery is not more than minimally invasive. Y'all are bright young people. If you can wrap your brain around that and explain it to me, please do. Well, of course, what's that old medicine joke? Minimally invasive surgery is when it's being performed on you. Major surgery is when it's being performed on me, right? But let's talk about something we've learned this year in the state of Tennessee. So we started these programs back in March. And as we were early into the series, we would ask surgeons in the audience, and there are surgeons here today, so you can agree or disagree. Is it the length of the incision that determines whether something is minor, minimally invasive, or major surgery? And by a show of hands consensus around the state, the surgeons have generally agreed, no, it is not. Those keyhole surgical incisions that Dr. Mancini talked about, we can remove a gallbladder through one of those. We can remove 80% of the stomach through one of those. So the surgeon community in Tennessee, I think the consensus is it's not the length of the incision. It is the procedure that is being imposed upon the patient that determines the answer to that question. And then the last question is, well, how do you report all this ICD-10 and medically necessary and all that? If it's a paper prescription, just write it on the prescription. If it's a called-in prescription, because remember, tramadol you can still call in because it's not a Schedule II, just tell the pharmacist what the ICD-10 code is, and if you have a medical necessity, if you have to add that. And then if you're e-prescribing, there are data fields in that e-prescribing platform where you can enter that information when you're sending in that prescription. Okay. Okay, so let's talk about, these are all new slides just today. We put these in this morning early, so that's why I'm rethinking how we do this program. Okay, so disposal of unused medications. Let me preface this by saying the diversion group field office in Nashville is adamant that we say all controlled substances and all drugs should be disposed of by a collection station deposit. You know, where you like the sheriff's office or police department, you got those collection boxes. They do not want anything flushed. They don't want anything put in regular trash because of ecosystem concerns. So here's what they are putting into the law in Tennessee. Return the medication to a pharmacy. Now, pharmacies can have collection stations. Not many have done this yet because the DEA rules on having a collection station in a pharmacy are horribly complex. The General Accounting Office recently issued a report telling the DEA the reason pharmacies have not put these collection stations in is because your regulations are way too burdensome. Go back and rewrite them. So we'll see if that happens, but that would be great if pharmacies could do that. I do want to make this point. If she's holding that vial with those 14 tablets in it, when you ask her where she got it filled, and she shows it to you and says, well, Doc, you just dispose of them. Do not take those back from her. Physicians cannot have collection stations. They're not allowed under the DEA rules to be a collection station. So do not take those back in your practice. Tell her to take them to the sheriff or police department or whatever. Now, the other thing is there are these substances out there, this is the third bullet, that they can get by going to a pharmacy and asking the pharmacist that you put those tablets in there, and that seals them in a way that they can then be disposed of in the trash. I know Walmart has that available, and typically they give it away free of charge so that people can use it for disposing. The drug take-back events are another. Now, I know this says flush down the toilet, But again, the DEA in Nashville is saying, no, 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 no. We disagree with the FDA and others, and so just remind your patients to dispose of it in a safe way. Now, here are the definitions. So on October 2nd, just a couple days ago, the CSMD committee met, and here are the definitions that were written. Dr. Michael Barron, who's the chair of the TMF, is who wrote these definitions, and they wordsmithed them a little bit. So physical trauma means a serious injury sustained due to surgical intervention or blunt or penetrating forces with the potential for serious blood loss, fracture, significant impairment, whether temporary or permanent, or disability or death. Blunt and penetrating, of course, blunt, the examples they talked about were MVAs and being thrust into the steering column or the windshield. And penetrating would be a GSW, a stab, typical things you'd see in an emergency department. Severe burn means an injury sustained from thermal or chemical causes resulting in second and third degree burns. I'm a little surprised here that somewhere in that definition they did not add a percentage coverage to the body. In other words, if I have a very small quarter-size chemical burn on the back of my hand, should I get an exemption for opioids for that quarter-size burn? I don't think that's what they intend. But they did not put any percentage of exposure on the body. So we'll see if they maybe come back and make any change there. So when we talk about the 180 MMEs, it doesn't take long to get up to that quantity. If you think about oxycodone versus hydrocodone versus codeine versus other agents, that then leads you into looking at the CDC table on conversion. Now, some of you may have downloaded the CDC app to your phone. I don't know if you have or not, but the CDC has an app that you can download that's got this data in it. Remember that hydrocodone and morphine equate at a value of 1. So if you're trying to reduce the 120 MMEs down from 120, you've got multimodality therapy, so non-drug therapy that you might use, and removing some of the opioid. Obviously, tapering patients from opioids would help get the amount down because you're reducing the amount of active ingredient. But the other thing would be to use other opioid agents, like codeine is 0.15 at the top. Down at the bottom, tapentadol, which is Nucynta by brand name, is a conversion factor of 0.4, and tramadol is a conversion factor of 0.1. With respect to tramadol, remember that in Tennessee, for all purposes, tramadol is an opioid. So when you're talking about this new law, we talk about calculating MMEs for this new law, tramadol is an opioid. Now, I'm not making any comment about clinical appropriateness of any of those agents. That's not what I'm doing. I'm simply showing you the conversion values in case that might be an opportunity. As clinicians, you would be the ones that would be evaluating whether any of those agents are appropriate. Okay, another new law, and this is a federal law. Under federal law, pharmacies could not partial fill Schedule II substances until this law was passed, except in 2 circumstances. One, they're about out of stock. And so if I walk in there with an OxyContin number 61 BID for 30-day course of therapy, and they've only got 50 tablets left, they're only going to give me maybe 4 to get me through 2 days and tell me to come back within 72 hours to get the balance. And if I did not get back within 72 hours, they could not fill it. And that's when they'd call you and say, sorry to bother you, doctor, but I need you to write another prescription because da-da-da-da. The second place partial filling was allowed was for LTCF patients, long-term care, or terminally ill patients. And there you could write a 60-day supply, and the pharmacist could partial fill in 7-day or 10-day or whatever days they wanted to over that 60-day period. This new law allows patients and prescribers to partial fill Schedule II. So back to my 60 OxyContin. The pharmacist walks out and says, this will be $185. And I go, oh my God, I can't afford that. I don't get paid. Now just give me 5 days worth. Under the old law, they couldn't do that. Financial ability to pay by the patient was not a basis for partial filling a Schedule II prescription. So now you could partial fill. You as a prescriber could ask for that. And I'll tell you the one place I've seen this come up already is where you've got a newly diagnosed adolescent ADD patient on a stimulant. They've never been exposed to that stimulant, but they live up in Meigs County, And so you write a 30-day prescription. You want to see how the child does. You put a note on there that says, pharmacist, just give 5 days, and I'll report back and let you know whether to release the additional 25. Because what you're going to do is have mom call you at day 6 and let you know how the therapy went, or at day 5. So you can use that for therapeutic trials, for one opportunity to use that. We do also know that patients are requesting this now. How many of you have had patients tell you about family members stealing their drugs? So if they always go to the pharmacy on the first day of the month and they get the full month's supply, what they're now asking the pharmacy to do is just give me 5 days. Because it's that same evening on the first day of the month that the 26-year-old grandson comes over and would take some of those hydrocodone. Now when he opens the bottle, there aren't very many in there compared to in the past. And now he's afraid to take them because he thinks Grandma will notice that he took them. Well, Grandma's already noticed that he was taking her hydrocodone. For some reason, he didn't think she did because she had so many in the bottle. So patients are now asking for that to avoid losing a lot of their substance on that initial filling. So that's a good new federal law. Now, earlier I said I would hang real tight to those MME maximums, and here's why. This is another new law enacted this year. The legislature created this task force and told the task force to establish a minimum disciplinary action. This only applies to opioids, but a minimum disciplinary action for a practitioner who is engaged in a significant deviation or pattern of deviation from sound medical judgment. Now, let's just suppose for a moment that the medical board has a case before it on overprescribing of opioids. Do you think they might use those thresholds as some kind of a guide as to what is the appropriate prescribing practice? I think they might do that. I think they could be led that way by a state's attorney. So this applies to all prescribing boards: optometry, podiatry, dentistry, nursing for nurse practitioners, osteopathic medical examiners, allopathic medical examiners. And so anybody that's a prescriber, this applies. So the task force has just met. This is hot. We hadn't got this slide in. This is so new. They just met. Now, what the legislature said is if the task force does not come up with a minimum disciplinary action, here's what it's going to be: loss of prescribing of opioids for 5 years. Well, the task force has proposed a stepwise penalty. So the first offense would be a $750 fine, a 6-month suspension of your ability to prescribe an opioid, and a CME course on opioid prescribing. As soon as you complete that CME course, you can now start prescribing opioids again. So if 1 week into the 6-month suspension, you complete the course, you can start writing opioids again. Second offense, $1,000 fine, 6-month suspension, and another CME course on opioids. However, this time the 6 months is a hard 6 months. Doesn't matter when you complete the CME course, you can't shorten that 6-month period. The third offense is a $5,000 fine and the 5 years of non-prescribing of opioids. So we'll see if the legislature accepts that report from the committee. All right, let's hear what Dr. Mancini says about multimodal therapies.
Now, as physicians, we're very data-driven, right? Our behavior is supposed to be changed by the data that comes to this. So if I can impress upon you the positive data that's out there about a non-opioid pathway for something that's as common as colon surgery, then I'd like to do that. Here's a large meta-analysis that looks at 2 groups: an opioid group, which is the standard care, and those that followed a multimodality pathway plan. And you can actually see here that not only did they have a shorter postoperative stay, they had less opioid in surgery, they had less opioid overall, they actually had better pain scores. So that should debunk some of the concerns that a multimodality approach doesn't treat pains for patients. It actually does, and they can have better outcome. So let's think about pain for just a minute. What this diagram shows is that pain can be treated at multiple locations. Now, if you think about opioids, they really just work on our brain. They don't work on the location of where the pain starts from, and they don't work at where our nerve bundles come into the spine. They only work on our perception of pain. The reality is that pain is interpreted in all these locations. So multimodality therapy should immediately have some appeal to it, right? Because we can use local injections at the spot where the pain starts. We can use NSAIDs to decrease inflammation. We can use spinal blocks and so forth to be able to reduce how much opioids are taking. Now, opioids are still going to be a part of our care, but they can be diminished. The other thing I don't think is given as much credence is thinking about how to treat pain without medications at all. See, there's a lot to the psychology of pain as there is the physical parts of pain. And I think we're too quick to do the prescription when there's actually a more of a behavioral change that can happen. There are easy things like heating pads or ice pads or elevation or deep breathing exercises, but it's also going to take an evolution into discussing with our patients. It's going to take time with us explaining to patients what those bad outcomes and why we're not prescribing opioids to begin with. We want our patients to be able to follow plans and feel cared for even when we go in a low opioid pathway. Working together, we'll be able to reduce this usage. It's hard to get people off these medications. It's easier to prevent it by not initiating opioid care. That's the real impact that we can have as surgeons and as primary care providers in our patients' lives.
So asking yourself, is this patient opioid naive? And if yes, can I keep them that way? And am I treating the primary condition or a symptom? You know, there's one case study that goes around about the patient that had breast cancer and was having pain associated with that, but also had a bad spine, was having pain associated with that. And so, you know, the pain is the symptom of which of those. And what the state is trying to say is don't treat the symptom if the symptom is the pain. Treat the underlying condition to try to remove the pain. Very simple concept the state's trying to talk about. Cochrane's study on pain relief, if assuming the patient is not contraindicated for ibuprofen and acetaminophen, 62.5% of patients reported 50% pain relief. Oxycodone, 15 milligrams, 21% reported 50% relief. You've seen the pain pyramid. The World Health Organization has the pain ladder. Starting out low with acetaminophen, NSAIDs, COX-2 inhibitors. Remember that gabapentinoids are now Schedule V controlled substances. The only impact that has on your continuing use of gabapentins for neuropathic pain or whatever is you got a 5 refill limit now. That's the only impact that has on your use of that agent and making sure it's for a legitimate medical purpose. Neuroblockade as we move up, and then finally opioids, but only if necessary. So what are some of those multimodal therapies, structural procedures, injections, open and interventional surgery, biomechanics? I was at a national medical exposition recently, and I went to the trade center part of that. A lot of exhibit booths sitting around, and I've never seen so many physicians sitting in these exhibit booths. Some of them had wires attached to their earlobes. Of course, that was biofeedback, right? They were doing some of that work. But then wires attached elsewhere, which were TENS units, transelectrical neurostimulation. And in the 80s, we used a lot of TENS units. But then, guess what? The insurance company stopped paying for it, and they fell to the wayside. But TENS units are coming back now, at least as evidenced at that place that I was. Chronic behavioral therapy. There are the psychologists, LCSWs, there's a series of CBT programs being done around Tennessee right now to teach them how to provide CBT to support what you're trying to do as a practitioner. Physical therapy. I hear MDs tell me about referring patients to chiropractors. The osteopathic branch of medicine, manipulation is part of their philosophy and concept of treatment. So the manipulation being part of that, acupuncture, massage, lifestyle changes, exercise therapy. You know, in my lifetime, drug therapy has been the real focus of treatment because post-World War II, the pharmaceutical industry really went into the R&D development of drugs and all that. I think in the younger individual's lifetime, I think we're going to see a lot of a lot of different modalities and a broader scope of modalities. In fact, there's a quaint little hospital in Houston, Texas. MD Anderson, that's it. Did you read this the other day? They're going to add hypnosis as part of their pre-surgical anesthesia protocol. So is hypnosis something that at some and that's been talked about a lot by physicians this year. How many of you have heard a physician talk about CBD oil and how they have patients that are on their own stopping their use of Xanax And I see a head nodding, Xanax and opioids. So I don't know what those therapies may be in the future, but my generation's been very drug focused. I think that's going to expand in time. And here's part of why I say that. The ALTO program at St. Joseph's Regional Medical Center in New Jersey. Bottom of that, it's alternatives to opioids, or opiates is what ALTO stands for. First 6 months, opioid use reduced by 38%. 75% of ALTO patients found relief without an opioid. So what they've done is they take medical conditions and they set these protocols up. So headache, migraine. Top right, you've got your injectable migraine product. Go down that list and you see haloperidol, Haldol. I've had physicians talk to me this year about how they use tricyclic antidepressants, how they use Vistaril as part of a more broad pain management regimen trying to avoid opioids. Extremity fracture, you see the things there, musculoskeletal pain. Well, there's those lidocaine or diclofenac patches that aren't paid for by many insurance companies. And then down at the bottom, there's a lidocaine patch there. Gabapentins gets added. CDC has done something similar. Look what they say about kidney stone pain, that NSAIDs are often just as effective, maybe even more effective than opioids in treating of kidney stone pain. So those are things that may or may not be helpful to you in managing pain. EPCS. So in Tennessee, the Department of Mental Health and Substance Abuse has told us that next year they're going to introduce legislation that would mandate e-prescribing in Tennessee. The only way you'd be able to issue a prescription would be electronically. You cannot write one. You can't call it into the pharmacy. It has to go through that e-prescribing protocol. We'll see if that happens. They're wanting an effective date of January 1, 2020. So if you've not gotten into the Seesaw system with DEA and your two-factor identification, your hard token and all that, something you'd need to do for prescribing controlled substances. Clinical decision support tools and EHRs. Those of you that are doing CPOE here at Erlanger, you recognize that, right? Because every time you try to enter an order, you get some kind of prompt back about drug allergy contraindication, drug-drug interaction, whatever it may be. But what about guidelines to therapy? Have those been incorporated into your EMR? And in the hospital setting, that's all pretty much in place. But out in the clinic world, it may not be as developed as it is in the hospitals. One of the advantages of e-prescribing, those of you that may be treating ADD in adolescents, and so you give them the 3 prescriptions, the multiple issue prescriptions, you would not need to do that anymore. You just issue prescriptions every month. So there are practitioners that I've seen this in their practices where every morning they turn on the computer and they push the button and this list comes up of the adolescent stimulant users whose stimulant therapy is going to run out in the next 2 or 3 days. And so on that day, we need to issue those prescriptions for those patients. And that avoids, because we do know that sometimes moms and dads take these prescriptions and try to get them filled early because mom and dad are using the therapy. We also had a situation in Knoxville where the physician had stopped putting the do not fill date on the 2nd and 3rd prescriptions, and the pharmacist was filling them. Did not catch what was going on. There was an audit. The insurance company clawed back $30,000 from the pharmacy on the basis that the 2nd and the 3rd prescriptions were not legal and should not have been filled. So let me remind you that if you are doing multiple issue, it's your responsibility to put the do not fill date on those 2nd and 3rd prescriptions. And also keep in mind, so if you prescribed those on September 30th, all 3 prescriptions have to be dated September 30th, right? Because all prescriptions have to be dated as of date of issuance for controlled substances. Don't put October 30 and November 30 on the next 2. Put October 28th. Give the patient a couple days of time, because if October 30th is a Sunday and the pharmacy's closed on Sunday, they can't get it on Saturday on the 29th. The pharmacy won't fill it. So give them a couple day window to be able to get to the pharmacy to get the medication. Controlled Substances Management Database. So this is what the dashboard looks like. The 40 MME is probably a more accurate number now than it would have been in the past. Of course, it doesn't include any unlawful opioids like heroin or other things that the patient may be using. But based on what we know they are being dispensed in Tennessee, it's a pretty accurate number. I want to mention the pay code on the far right, that 04 at the bottom. That's becoming more important because you see on this panel, you've got the 4 primary sources of payment for prescriptions. Private pay, cash paying, Medicaid or TennCare in our state, Medicare, and commercial insurance. So if this is your patient, you're looking at this and you had thought about prescribing OxyContin, you see that 04, and thinking about what we said earlier, oh gosh, I guess I need to go and make sure it's not Blue Cross Blue Shield, it's the commercial insurer, because if it is, and I write OxyContin, I'm going to get a call back from the pharmacy because they don't pay for it. So the point is, not only do you have to know all these laws we've been talking about, now you must know the payor policies on what they will approve. As another example, in January, Medicare is putting hard edits on Part D beneficiaries on opioid therapy. They're talking like 7-day max, except for some exceptions like surgical, things like that. TennCare is already doing some of that. And of course, private pay, that's not as applicable. So knowing that pay code may be of value to you. Prescription by practitioner. Every year or every other year when we do these programs, I have physicians come up and tell me a story about how they were identified in the database as being the practitioner for some patient wasn't their patient. So it's valuable to go in there and look at that every now and then just to make sure the pharmacy has not accidentally put your provider code on a patient that's not your patient. And remember, if you find that, if you scroll down to the bottom of the patient's record in the database, you'll see the pharmacies listed that submitted that data. That's who you call. That's where that change has to be made. The pharmacy's got to go in and make that change. And you can also look at your supervisees' histories. So if you're a collaborating physician, you want to see, well, what are my APRN, PAC, what are they writing? I need to look at that. You can also look at your rank among your colleagues and peers. So over on the far right, we got 3,243 general, internal, or family medicine docs in Tennessee. Practitioner number 1 is 27 out of those. This, by the way, is a place where being number 1 is not a good thing. Okay, you don't want to be up there at number 1. But it may be okay if practitioner 1, if 80% of his practice or her practice are sickle cell patients because he runs a sickle cell clinic, that probably explains why we're at number 27. But I want to tell you about something that I have come to realize this year. Because we were in a program, one of the dinner programs, and after the program, a physician came up with his phone, and he said, I'm really concerned about this ranking. Because while we were having the program, he got on his phone and went to the database to see what his ranking was. And based on what he told me he prescribes, I was a little surprised he was in that ranking as well. Well, over the next couple of months, in thinking about that and talking to individuals, here's a phenomena that's beginning to occur in our state. We have a lot of PAs now in our state because we got a lot of and more programs starting, including UT bringing a program here to Chattanooga. So think about this. So 80% of my practice is sickle cell patients. And I decide I'm tired of treating sickle cell patients. I want to do some other things. I want to mix up my patient mix a little bit. I want to diversify some. So I go out and I hire an APRN or a PAC, and I transition all those sickle cell patients to that person. And I stop writing opioids because I'm over here treating things that don't require controlled substance prescribing. What's going to happen? I'm going to go down in that ranking. And every time one of us goes down, everybody else above us goes up one more notch. You see what I'm saying? So I asked him, I said, tell me what you think's going on. He said, I'm the only person in my practice. I'm solo. I write all the prescriptions. He doesn't have any buffer. You see, does that make sense to you? So the more that we transition chronic pain management, as an example, or chronic stimulant use to APRs and PACs, those practitioners that still write all that because they haven't hired an APRN or a PAC are going to go up in rank. So I think that's another reason if you look at this and you go, oh my God, how did I get that high? I think that's another reason for you to consider is that you don't have an APRN or a PAC. Does that make sense to everybody? Okay, good. All right, so let's talk about our chronic pain guidelines in Tennessee for a moment. Because remember, this new law in Tennessee does not displace those guidelines. So if you're at 90 plus days of opioid therapy, you're over here now looking at the guidelines. So first is lowest effective dose of 90 to 120 MMEs, no methadone for pain management. Now the third bullet is important perhaps in some patients. The guidelines say that you cannot use buprenorphine for pain management, to treat pain. However, there are two agents that carry an FDA-approved indication for pain, two buprenorphine agents. One is Butrans and the other is Belbuca. So if you're wanting to go to a non-opioid pathway with a pain management patient, those agents might be available for you clinically. That's something you would have to determine. But there are two buprenorphine products, Belbuca and Butrans, that you can use under the guidelines for pain management because they carry an FDA-approved indication. That's why the guidelines originally said you can't use buprenorphines, because it wasn't FDA-approved for pain management. Now you've got two agents that are. No minimum requirement for in-person follow-up. Well, look at what the CDC says. If you initiate opioid therapy or you escalate a dose due to tolerance perhaps, they want you to contact the patient 1 to 4 weeks. That's a phone call, not a in the presence of visit. Once you contact the patient, check on them. Then they want you to see that patient every 3 months as a chronic opioid patient. Well, look, at Tennessee, we don't have any requirement or recommendation for chronic therapy and chronic visits visits for chronic therapy. So you might think about, do I want to get patients back in here? Once again, that's a billable encounter to get them back into the office for follow-up. But also, and again, I'm not trying to drive up the cost of health care, but I'm also thinking back to that Covaris study. Now you know why we put the Covaris study in there, right? Because what did it say 15% of the time? We were not managing and monitoring clinical status. Remember that early slide? So maybe it's not a bad idea to get them in maybe every 6 months, maybe quarterly. That's your decision. But think about that, because you go over here on the right side, follow-up chronic opioid therapy, fourth bullet down, every 3 months. Monitor, the guidelines say UDTs at onset and minimum twice a year. CSMD, you now know you have to check it twice a year, and no telemedicine as part of the chronic pain management. You have to, if you're going to see the patient, you must see them in the presence of physically, not by telemedicine. And then down at the bottom, you got 3 things that are in both guidelines: avoid concomitant benzos, therapeutic trial, informed consent, and having a treatment agreement in place. The 5 A's associated with prescribing analgesia, aberrant behaviors, affect analgesia, activities of daily living, and adverse side effects. Now, in the chronic pain management guidelines, they talk about the PEG scale. So the P stands for pain average. So today I come to your practice. I'm a chronic opioid user for whatever painful condition I have. And I'm asking triage, what's your pain value today? And I say, oh my God, it's a 12. Whoever writes that down, passes it on to you or puts it in the record. You walk in and you say, Fitzgerald, what in the world is the problem here? Why do you have a 12 today? Because I've looked back, because I'm doing an average. I've kept depth of data. I've got all these pain scores going back in time. You've been 2, 3, 1, 2, 2. Why are you saying 12 today? What the state is saying in these guidelines is find out what's going on. But don't do this. Don't escalate the opioid therapy. Use some adjunct. Find out what happened. And if I have pulled my lower back because I helped my son move furniture into an apartment on campus or something like that, then don't escalate my opioid dose. Find some other way to manage that painful encounter. Interference with the enjoyment of life and interference with general activity. Medicare Quality Payment Program. Do the acronyms MACRA and MIPS mean anything? Yeah, I see heads nodding. Yeah. So if you want to make practice administrators and practice managers happy, monitoring patient functionality is key now in that Medicare Quality Payment Program. So anybody using the Barthel Index of Daily Living as one example, or the Lincoln-Norrie scale? So the Barthel Index of Daily Living has questions like, Do you bathe yourself? Do you dress yourself? Do you clean your own home? Do you cook your own meals? Do you do your own grocery shopping? Do you do your own yard work? Do you do your own driving? All those questions. Have patients fill that out, and then have the staff identify where they have said no. And if the no is because they're just lazy, there's not a lot you can do about it, right? But if they say no because it hurts too bad, if I run the vacuum cleaner, my back will kill me the next day. So if we can then get some of those no's converted over to yeses, we pass that to the practice administrator. They're going to do cartwheels down the hall, because that's the kind of data that feeds into those quality ratings in the Medicare Quality Payment Program. So then those incentive payments, those PQRI and all those other kinds of things, those quality payments start growing for the medical practice because of improved quality. We've already talked about the tiers with 120 in Tennessee. I'll skip that. This is new in our slides this year, and that is the 5 C's associated with opioid prescribing. Loss of control, compulsive use, craving drug, continued use, and chronic problem. These are the buzzwords that tie into the federal law definition of an addict. So when you start seeing these things developing in a patient, think addiction, because they really correlate well with the federal definition of what an addict is. Reminder that we need to be sure and tell patients that with long-acting opioids not to crush those or chew them because of immediate release or rapid release and resulting in overdose and death. A study of opioids and non-fatal overdoses, 3,000 patients in the study. Look at this, 10 months post-overdose, 91% of those patients were still receiving opioid prescriptions, even though they had a non-fatal overdose. 61% of the time is the same clinician prescribing the opioid. That's startling, but is it surprising? No. It's not surprising because we don't have a system for reporting of non-fatal overdoses. However, the American Hospital Association has been challenged to create a reporting system out of emergency departments for non-fatal overdoses. The CSMD would love to have that data because they'll put that column in the CSMD in Tennessee. So if you go to that database and you see that the patients had a non-fatal overdose, then you can jump over to the AMA guidelines on when to add the reversal agent Narcan and to whom to give it to and all those things that are in those AMA guidelines. Tapering, we've talked about already. The Tennessee Department of Health guidelines. So again, once you jump over there to the guidelines, you leave the new law in Tennessee, you're in the guidelines, start tapering the patient using this guideline, or you could use the CDC guideline. So go slow, consult, support, and encourage. I know that one of the things that we're beginning to see is that you taper patients down to 0 active ingredient. If they don't have a support group, sometimes they're not successful in staying off the medication. So something like Narcotics Anonymous might be helpful. Had a physician up in Knoxville programs a couple months ago, and after the program he came up and he said, I'm in a very rural area, I don't even have AA, let alone NA. He said, let me tell you what I did. I went to Knoxville and found a licensed clinical social worker, and she comes out to my very rural community one night a week, and I require my patients to go, and she does CBT, cognitive behavioral therapy. I require them to go at least twice a month to see her. They have to pay her cash out of pocket at $10 a person per 1 hour evening program. My analogy would be, you've got a newly diagnosed adult onset type 2 diabetes mellitus patient. What do we do with them? We send them to diabetes self-management training, right, at the hospital or wherever it's available. It's an analogy. They go to this training program, and he said, I've had great success with it. He said, I've only had a few patients that have refused to pay the money, and they're not my patients anymore. I require them to go to that. So think about how, once you taper, what are you going to do with that patient? Chantix is another example of that. If there's not support for the person that stopped smoking, sometimes they start smoking again, is another example of that phenomenon. The call for team-based care. The core team on the left is not by any particular order of priority or significance of the individual. It's just the list we put them in. Now, I think the most important thing here is the messaging. we've heard reports this year from you guys about situations where, so you're the PCP, and you've got whatever condition, and you've convinced the patient that you can control their pain adequately with Tylenol and ibuprofen. And they go to the physical therapist or some other member of the team, and they say, well, I've looked at your scans, and I'll bet you're really hurting, aren't you? What opioid did your doctor give you? Well, I'm not hurting, but well, maybe I should now that you've said that. Remember what Dr. Mancini, the psychology of pain. So if the team members are not messaging the same, that's creating conflict. And so again, I would encourage you, whoever's responsible for the building of this team, to make sure the messaging through that team is consistent. Now on the far right is the wider multidisciplinary team. The pharmacist, well, I mentioned medical social worker, LCSW, just a moment ago for the Narcotics Anonymous backup. Pharmacists, that state of Franklin Healthcare Associates in Tri-Cities, they have 2 pharmacists on staff in that medical group. They're not dispensing drugs, they're clinical support, but they have medical students from ETSU and LMU DCOM, and they also have pharmacy students from ETSU. They've put those students together in teams to do medication reconciliation and to do other things. And so again, how can you use those individuals to help manage pain patients and be part of the team? And I know that from South College, you got pharmacy students down here, because I see a couple of them sitting in the back of the room back there. So how do you build ththose teams? Dr. Worthington and I have talked about that in the past, about having those students from medicine and pharmacy working together. And there are protocols that you can build there too to help identify issues with some of the patients. Dietitians, if obesity is the cause of the pain in the hips, maybe we get them on a weight reduction program, so a dietitian might be helpful. Don't think about just diabetes for dietitians. So think about who all is on your team. What's the advantage of the team? Care is delivered in a programmed and coordinated manner, provides continuity of interaction and care, facilitates early and accurate diagnosis, faster return to work. Some of that social determinants, population health research that's going on, tells us that patients that are unemployed are more likely to use controlled substances. And depending on how long they're unemployed, they start doing really bad things like selling drugs and trafficking in drugs because they need the money. So back to this, if we've got that occupational therapist on the team, maybe we can find employment for them and avoid that. And then more focused response to patients' questions. Well, again, the broader the team, the more resource you have to answer questions. Let's hear Dr. Mancini's closing remarks.
So the tide is changing in the favor of physicians empowered to change the care for their patients. You're going to get a lot more support in the coming days with regards to this from multiple different locations. And instead of it feeling like a burden, my hope is that you leave today understanding that your role is to understand how you can change the behavior of yourself with regards to prescribing that's going to change things for patients. So when we work with these organizations, and as the American Pain Society or SVMIC or the state of Tennessee, the Tennessee Medical Association, everyone is looking to help. But at the end of the day, the thing that's going to make the greatest impact is we as physicians own this opioid prescribing issue, change our prescription habits. We do it one patient and one prescription at a time. I thank you.
So what we are doing in Tennessee is we are trying to build a jigsaw puzzle. So the pieces we've talked about today, screening tools, CSMD, therapies, team care, the guidelines, and then laws that are being changed. There are 2 other pieces. We've also talked about health payment reform, so maybe we'll get some of that, and then patient education. The Department of Health is doing a good bit of that, where they're putting brochures out in the community for patients to learn more about opioids and managing these substances. Well, I think we're right against the hour. Yes, we are. So we're doing another program at 5:30, so I'll be around this afternoon. If any of you have any questions, I don't want to hold everybody else up for questions. So if you are a practitioner who needed this program for your CME, for relicensure, here's the number on the next slide you'll need. Thanks for coming. It's been a privilege to come back this year and be part of your CME programming, and there's the number you need. Best wishes to you guys.